other folks will pop in shortly. Um, so probably got the announcement about the school potentially opening back up on 22nd. My From reading the letter that Nikki put out, my interpretation was that was under the assumption that we were about to go to green as far as the state is concerned, and I'm not sure that that's when that's going to happen. If you've looked at the case numbers for coronavirus, it's been nuts the last week and a half, highest throughout the whole thing. So to me, scientifically speaking, it makes absolutely no sense to go to green. So I'm not sure what the governor's going to do. As much as people would like to get back into normal society, I think when we went from orange to yellow, we had a lot of people that just let their guard down, I think, is part of what's driving that spike, started getting together in bigger groups, meeting with extended family, and then certainly having mass protests with a lot of people in close proximity isn't helping things either. So I think there's kind of a twofold cause of this spike. So if we do end up opening by the 22nd, we are going to have our tutor available. And I don't know if Greg had mentioned that at all in any messages that he sent out. For the last number of years, we've had a tutor that's available for both nursing and PTA students, primarily for anatomy and physiology. The guy that we've been using is finishing up his DPT at Rocky Mountain University, so he was great help for our students, and he would end up tutoring for a lot of the other classes too. So for our second year folks, he would kind of help with some of the more advanced stuff besides just A&P. So if right now he's scheduled to be on campus from 4 to 6 on Tuesdays and Thursdays. Again, and he's supposed to start that week of the 22nd. But again, I'm not 100% sure if that's going to come to fruition at that date. We'll just have to kind of see what happens. I think the governor, when he went, decided not to go to green last week, just extended the order for another week. So I think come Friday or Saturday of this week, he'll probably make another announcement, one direction or the other, either maintaining status quo or trying to advance to green. Really, the numbers weren't going the other way more than anything. Given that they're higher than they've ever been, it would make more logical sense to actually go orange instead of green. But that's just me looking at science and numbers. So, all right, let's get going on our next chapter, which is chapter 9. And this is the last chapter before the next written exam. Chances are good we have the rest of this week to cover it. So we should have some time on Thursday to probably review a little bit, possibly even start in on chapter 10. Nothing on chapter 10 would be, if we do start it on Thursday, nothing in chapter 10 would be on the next exam. It's just going to be chapters 6 through 9. So pretty much bone, axial skeleton, appendicular skeleton, and then the joints. So pretty concise and very interrelated group of concepts, not quite as divergent as that first test where we had a lot of different things to kind of cover.
I have a question.
Yep.
So, will there still be Zoom meetings?
If we go full on campus, there won't be. We'll hold class on site and then have lab on site right after it. And then I guess you have intro today or you have intro on Thursday.
Okay.
Whichever day today. So you'd have that on as well.
So if we go full green, then we don't have to worry about coronavirus, or should we just keep our guard up?
I'm assuming that we're going to probably maintain the same things that we're doing with our current students on campus right now, which is everybody wearing masks, having to fill out the screening form when you walk into the building to confirm that you don't have any symptoms. They've been taking everybody's temperature. Everybody has to wear masks while they're on campus. So I think the green designation is more just about group size, but I think the recommendations for social distancing and mask wearing when you're in close proximity to other people is still probably going to be enforced because the coronavirus is not going anywhere anytime soon. It doesn't appear. So that would be my assumption. But it would kind of depend on the full announcements. And, we've been doing it for the last month, I guess, almost on campus with the second year students, and it seems to be working well. Nobody that I'm aware of has developed any kind of symptoms or had to miss any class, but all it takes is one person coming down with it and getting diagnosed positive to kind of change things in a hurry. So I think we all need to kind of keep our guard up and keep doing what we can to minimize that person-to-person spread that we know is associated with that condition. So, all right. So let's move into chapter 9. Let me get my screen switched over. All right. So we're going to go over the different joints in the body and kind of talk about different joint types. We've got a couple different ways that we can kind of classify them. We'll look at the different motions that are allowable or that are able to be performed at the various joint types. Some we don't want to move much at all. Some are going to move a lot. And it kind of depends on what body part it is and what function we need out of that body part, how much motion we kind of want. So this term articulation, don't be thrown by it. It just means that's a joint where two bones are meeting up. And typically it's going to be bone to bone. We do have certain joint types that have a more cartilage connection to it. So you've got kind of a chunk of cartilage that's in between two bones. But in most cases, you're just talking about bone on bone with the articular cartilage covering the ends of the bone. The other joint type that is considered a cartilaginous joint is going to have a fibrocartilage kind of chunk usually. Sometimes it has a bigger piece of hyaline cartilage, like when we talk about the ribs. But we'll get to that in a bit. So this kind of second big bullet point on this slide here talks about these terms stability and mobility. And the last little hash mark there on the bottom, that dash, more mobility equals less stability, and vice versa. And so that's really how our joints are set up. Things that we don't want to move much, like say the joints in our skull, we don't want those bones shifting around because then it makes our brain susceptible to injury. We want this very rigid shell. Those joints are very immobile. When we look at something like the shoulder, where we have a really shallow glenoid cavity and a really big humeral head and a really loose joint capsule, gives us the ability to move that arm in a ton of different directions, which allows us to reach, bend, twist behind us, in front of us, across our body, up, down, every which direction. So the shoulder is considered to be our most mobile joint. The sutures in the skull pretty much going to be the least mobile type one. So those are kind of the two extremes. When we look at things like our knee, our spine, our jaw, our toes, those are somewhere in between. They're not going to be as stable as the skull sutures, but they're not going to be anywhere near as mobile as the shoulder is. So a lot of it is determined by kind of the shapes of the bone ends, kind of how they fit together. But a lot of it definitely is about function. When we look at our leg joints, they tend to be a lot more limited in motion than our arm joints. And it makes sense because we stand on our legs, we have to support all of our body weight on our legs. And if those joints had a lot of extra motion, then our muscles would have to work that much harder to kind of hold us in place. If the shape of the bones fitting together, along with the support provided by the ligaments and the joint capsule are sufficient to keep a joint stable, then the muscles don't have to work as hard. So it's not as fatiguing for us to stand. And so we want that stability. When we think about each step that we take, we don't want our bones to be shifting around a whole lot because that's going to create extra work and potentially extra kind of wear and tear on the joints. So our arms, because we use them to manipulate stuff and have to, open things, lift things, screw things down, whatever objects we're trying to act on, we pretty much use our hands to do it. We need a lot of dexterity. And in order to have that dexterity, we've got to have more laxity in the joints to let them have bigger arcs of motion more freely moving joint, so the muscles don't have to fight tension trying to stretch joint capsules and trying to stretch tendons as far to let us, like say, sew or chop or anything else, change a baby's diaper or whatever we need to do to kind of use some finger control and grasp and dexterity. So as we go through the body, we'll kind of point out what motions different joints allow to happen and which ones kind of need that extra motion and why, and which ones we might need to be more stable. So this slide kind of looks at that whole gamut. It doesn't include every single joint in the body by any means, but it lists some of the big ones. So we've got our two, what we call ball and socket joints, and those are going to be kind of our most mobile joints, are going to be the ball and socket type. So we've got the glenohumeral joint is essentially just that intersection between the fossa of the scapula, that glenoid fossa or glenoid cavity, and that humeral head fitting right together. And then get a scapula out. So I'll try and find one in a bit. We do have the scapula, and the scapula moves independently of the humerus. So, and it's considered part of what we often call the scapulothoracic joint, which isn't really a true joint. The scapula is not making, there's no joint surface that's making contact with the ribs in a specific location. The scapula is held in place by muscles and connective tissue. So it's not really a true joint, even though it does move. And the fact that the scapula is mobile is a lot of what gives us the ability to move our arm in so many different directions. If we look at the other ball and socket joint that we have, that hip joint, the pelvis is much more solid. We have that pelvis, we talked about the pelvis last time, got that nice big ring made up of those two os coxae bone, the sacrum, the coccyx, the pubic symphysis, kind of holding it all together. While there is a little bit of motion in the pelvis, it needs to be really stable because that's what's transferring the weight, our body weight to our leg and from the ground up our leg to the body. So it needs to be a lot more stable. So even though the shoulder and the hip are both the same type of joint, the shoulder has a lot more motion available and the hip is a lot more stable because of its deeper socket and much tighter joint capsule and much tighter set of ligaments. And then we think about the muscles that surround it, things like our glutes and our quads and our hamstrings are way bigger muscles than our delts and our pecs and things like that. So we don't have it, so that extra muscle mass helps contribute to the stability of the hip versus the shoulder, but so does the inherent shape of the joint. That has a lot to do with it. If we look at our elbow, we've got really a couple different joints going on in the elbow. We've got kind of the primary elbow joint that we think of, and that's where the ulna and the humerus meet. And so that is considered a hinge joint, which is just going to bend and straighten. Where the radius and the ulna meet, that's what gives us the ability to kind of turn our hand and our arm over itself like this. And so that's a different type of joint. So that when we look at this picture that has the elbow right in the middle of it, we're really looking at two different joints. They're really kind of three, because you can consider the humeral ulnar as one joint. That's kind of the elbow joint proper that we think of. You do have a point of contact between the radius and the humerus, where that capitulum is. And then we also are then going to have where the two forearm bones meet up against each other kind of side by side. And we have contact between those bones both at the proximal end close to the elbow and at the distal end. So we name those joints the same, except we designate whether it's the proximal or the distal. So we have the proximal radial-ulnar joint and the distal radial-ulnar joint. So like I say, in this elbow picture, essentially we have three joints: the humeral-ulnar, the radiohumeral, and the radial-ulnar are shown there. When we look at the vertebrae, we're actually looking at a couple different joint types there as well. So where the bodies of the vertebrae are, the big blocky chunky part in the front of the bone, we've got the discs in between. And so those discs are an example of the cartilaginous joint. The two bones don't make direct contact with each other. They're separated by that spacer that is attached to both of them. So if we look at this, the top disc, it's going to be adhered to the underside of the top vertebrae, and it's going to be adhered to the top side of the bottom vertebrae. And so that is essentially like glued to them. But the fact that the disc is pliable and those the connective tissue that makes up that disc can kind of give and stretch and bend and twist helps the overall spine move a lot more effectively. But it's a very stable kind of a joint as long as those discs stay intact. On the back side, we have our facet joints. And so those facet joints, if you remember when we learned about the vertebrae, we have the superior articular facet and the inferior articular facet. And those two things are going to kind of overlap if you think about like shingles kind of, where they're going to be stacked on top of each other. And depending on if we're looking at cervical, thoracic, or lumbar, how those facets are angled does vary a little bit. And that gives different parts of the spine more movement in some directions than others. And then our skull, we do see more than just one joint with this skull. What are some, we've got the suture lines, and so that's a type of joint that's considered a fibrous joint, where they, in adulthood, they should all be really fused together and really shouldn't move at all. So that's our least mobile. What other joints do we see on this skull from this side view?
It's the jaw, the mandible connected to the skull part.
Okay, so we've got our TMJ joint, our temporal mandibular joint, and most of these joint names are going to be based on the two bones or three bones that are involved in that joint. So we do have the TMJ joint, and that's kind of an interesting joint. We'll spend a little bit of time looking at it either today or tomorrow or Thursday. We can open and close our jaw, and that's considered, it's functioning like a hinge joint in that case. If you think about like a door, we're just kind of pivoting. We've got one kind of posterior pivot point that things are opening and closing. I guess I should do it this way. I can't make my right hand, I don't have that much. So if I'm letting that bottom jaw drop down and coming up. But we can also stick our jaw out. So it has an additional motion that most hinge joints are not going to have. So it has the ability to also glide forward and then retract back a little bit too. Not nearly as much motion as we have in, opening our mouth, but it still is a distinct motion, and we have muscles that control our ability to do that. So we do have that joint, again, that's just kind of unique. Got at least one other joint type in that skull picture. It's not one that we think that should really move a whole lot. Anyone? No? Kim?
Is it where the cheek, the zygomatic, and the temporal bone meet?
No, I think that would be more like fused, kind of like the sutures.
Okay.
Something that was separate pieces of bone in development, but then as we got older and matured, it should be kind of locked together. So the other ones are where our teeth are sitting in our jaw, both top and bottom. So that's another type of joint. It's considered to be a fibrous joint, like the sutures in the skull. It's not really meant to move, but something is holding those teeth in place. And when the protective ligaments that anchor that in fail, or you have tooth decay that weakens that adherence into the socket, then we can have teeth come out, or if we get enough force. Thinking about boxers, MMA people, or Tom Hanks in Castaway when he got the ice skate and took out his own tooth. We can definitely loosen those joints out and essentially dislocate that bone, the bone being the tooth. So that's another joint type, and it should be stable. So let's kind of look at kind of classifications. So structurally, and I've used these terms a little bit already, we've got our fibrous joints. And those are ones that are typically not really meant to move. It is two or more bones meeting with each other. but then we just have these fibrous connections that are meant to just hold those things tight together. Our cartilaginous bones, our joints are going to have like those discs that we saw in that last picture. We've got bone, then we've got a section of cartilage, and then we've got a bone. And so that cartilage is what's binding the two bones together rather than like extra ligaments or surrounding joint capsule that's kind of helping support them. And then our synovial joints are really what most people think of when you talk about a joint. These are the joints that give us motion. So when we think about our shoulder, our elbow, our knee, our hip, our finger joints, our toe joints, those are all synovial joints. So they're meant to move. And we've got 6 different types that we'll look at that allow certain types of motions. So those are kind of 3 ways to classify it by their structure. Is it held together by fibers? Is it held together by cartilage? Or is it surrounded by what we call this synovial capsule? And so the synovial capsule, or the joint membrane, essentially, is, if you think about like a neoprene sleeve that people wear on their knee for support, it's kind of like that. It's not going to have a hole in the middle for your kneecap like some of those do, but it extends up high enough up on your thigh to cover the distal part of the femur, and it extends down below the knee low enough that it surrounds that proximal tibia. And so it's basically like a sleeve of connective tissue, and we'll look at how synovial membranes are structured in just a bit, but it's encapsulating that whole joint. And inside of that cavity, we're going to have some fluid that's called synovial fluid, and it's kind of an oily mixture that the body produces. We have certain cells, epithelial cells in that synovial lining that make that fluid, and that fluid is essentially like lubricating fluid. If you think of your car's engine, how, if you don't have oil, the engine's going to burn up. We need to reduce that friction and make those engine parts glide against each other without just grinding on each other. That's kind of the purpose of that synovial fluid. We want it to lubricate and ease movement, take away friction, and make things move really nicely and smoothly. So that's one way to classify the joints. The other way down at the bottom is by function. Essentially, how much motion do they allow? And we do have, for these first 2 structural types, the fibrous and the cartilaginous, each of those includes both the synarthrosis type and the amphiarthrosis type. So it would be easier if we just said, well, fibrous, they're like synarthrosis; cartilaginous, they're like amphiarthrosis; and synovial, they're like diarthrosis. And it doesn't work that way. The synovial are essentially the same as diarthrodial or diarthrosis, but the fibrous, we have some fibrous joint types that are considered synarthrosis. We have some fibrous joint types that are considered amphiarthrosis, and then same thing with the cartilaginous. We're going to have some cartilaginous joints that are considered synarthrosis, and we have some cartilaginous joints that are considered amphiarthrosis. So let's look at some examples of those, and we'll talk about these different joint types. So this one kind of has all those first 2 categories when we look at the structural type. So within our fibrous, if you go all the way over to the right, we've got our functional classifications. So this first one, this term gomphosis, that's our teeth in our jaw. We have a deep socket where that bony tooth is embedded down in there. We're going to have a lot of ligaments that they call periodontal ligaments that are basically anchoring the bones together. So they shouldn't really move a whole lot. There's no joint capsule, there's no fluid within there. It's just this pretty solid connection with a bunch of individual, essentially ligament fibers that are growing and connecting the tooth to the jaw. So that's considered immobile. It's a synarthrosis. We don't really want it to move. Obviously, we can dislodge things, but it's not meant to happen. The sutures in our skull are the other really common synarthrosis fibrous joint. And again, once, when we're a little kid, they're not quite solid, they're not quite fused together. Certainly the younger that child is, the less solid those connections are going to be. But pretty early on in childhood, we're going to get those things pretty anchored together. Now, as a kid grows from being 2 to being 4 to being 6 to being 12 to being 16, their head's going to get bigger. So we can't have those sutures form too tightly at too early of an age, or it wouldn't let the skull continue to expand. But once we get to 18, 20, when we're kind of more at our kind of skeletal maturity age, then those things are really going to lock down and not really, because the skull bones aren't going to get any bigger. There's no reason not to go ahead and seal things up and make a really tight connection with those. So again, mostly both these two types are just lots of connective tissue that's holding things together. No movement, there's no articular cartilage, there's no hyaline cartilage covering the ends of the bones, because those bones aren't really meant to move relative to one another. They're meant to be held together. Our last fibrous type, this syndesmosis, is considered to be an amphiarthroidal joint. So it has to move, it's going to allow it to move a little bit. It's mostly stable, but it does have a little bit of motion in there. And we've really only got kind of 2 examples of that, and that's in the forearm between the radius and the ulna, and then in the lower leg between the tibia and the fibula. So we have this sheet of connective tissue that we call the interosseous membrane that essentially is anchoring those things together. Pull my skeleton up here. And see if I can angle that down. So when we look at the foot and ankle right here, you're going to have ligaments that are running. Trying to get my camera to work, and this leg doesn't have enough range. I'm going to tip him over. So at the distal end, we've got that lateral malleolus, we've got the medial malleolus. We're going to have some ligaments that run horizontally that are holding this distal end of these 2 bones together. We're going to have some ligaments up top that are holding that fibular head against the tibia. So we do have connections here, but pretty much all in this hollow space, we're going to have this sheet of collagen, just connective tissue. And the lower leg, when we weight bear and stuff, you're going to get a little bit of gapping between there. But this one is a more stable syndesmotic joint than we would see in the forearm. In the forearm, let me get him turned around a little bit and raise you up here. So in the forearm, same thing. We're going to have some ligaments going side to side between the radius, the radius and the ulna. Proximally, we're going to have the same thing, some ligaments anchoring things together. But in between those 2 bones, we've got that sheet of connective tissue. In the leg, we don't want a lot of extra motion between those distal leg bones, because we have to bear weight on it. We have to push off the ground, to step, to walk, to run, to jump, all those type of things. But in the arm, we need to have more give to it, because we need to be able to turn our hands over and back from each other. We need to be able to go through a kind of a bigger arc of motion at our elbow than we typically have at the knee, and be able to have a lot more dexterity in that. So they both have the same arrangement, but the forearm is not going to be nearly as immobile of a syndesmotic joint as the tib-fib articulation is. So we need that stability in the leg to support body weight, but we need that extra motion in the arm to give us that ability to manipulate things and use our hands more effectively. But the same general type. So those are kind of our 3 fibrous types, the gomphosis, the suture, and the syndesmosis. And you want to know which one, while they're all fibrous, only the first 2 are the synarthrodial type, and only the syndesmosis is the amphiarthroidal type. Okay. Cartilaginous, we've got 2 different types. So we've got a synchondrosis, and that's considered to be a synarthrodial joint, so it's not meant to really move. And then we have a symphysis. And so the symphysis is like the discs in the back that we talked about. We have a chunk of fibrocartilage between those bones. And that fibrocartilage is anchored to both bones, but it's going to be way more mobile than just having fibrous connective tissues holding things together. So our symphysis is amphiarthroidal, but our synchondrosis is considered synarthrodial. We'll look at some pictures here in a second, and we'll kind of point those things out. I do have don't really agree with your book with one of these joints, because I think they call something a joint that's not really meant to be a joint. But we'll talk about that.
For that synchondrosis one, where the hyaline cartilage is, you said that is located on the sternum, that connects the ribs to it, correct?
Yep.
Does that allow it to expand slightly for the lungs, or does that remain in place and that's why we can't expand completely or we run out of room?
Well, so let me flip this up a little bit. So we've actually got right on where the sternum connects to that piece of cartilage is considered a synchondrosis, and then we also have where the rib connects to it. And so while we're not meant to have movement where the bone ends connect to that piece of cartilage, that piece of cartilage itself is flexible. And so we don't want the motion taking place at the joints, but that cartilage can bend and give a little bit. So when we inhale, we do have, our ribs are going to connect back in the back too, on the vertebrae. And so those are actually synovial joints that will allow for some motion, some pivoting back here. But on the front side, it's mostly just that those cartilage sections are flexible. And so they work kind of together to give us limited movement of the rib cage.
Gotcha.
But because the rib cage is super important in keeping our heart and our lungs safe, we don't want it to be too flexible. If it was too flexible, then we'd have the risk of, too easily compressing the heart and running into some trouble there, or too easily compressing down the ribs and keeping them from functioning. So
Makes sense.
we need some rigidity, but we definitely need to be able to, pull on our lungs and help them expand and get good airflow. I realized I didn't have my chat up, so let me put that up real quick in case anybody's asked me anything that way. Well, I thought I clicked it up, but now I don't see it. Let me try that again. It's probably hiding somewhere. I've got too many screens up. My chat box disappeared. One more time. Let's see. There's my chat. Now it's stuck in there. All right, now I'm good. All right. Let's talk about our synovial joint types, and then we'll look at some images and kind of help clarify things a little bit. So this whole page is all the different synovial types. And these are the joints that have that capsule, that sleeve, that have the fluid in between. Typically, we're going to have some supporting ligaments in addition to that joint capsule that give some integrity and stability to the joint. But all of the ends of the bones are going to be covered with that hyaline cartilage, that articular cartilage, because we want them moving relative to each other to give us the different motions that these joint types allow. We've got that joint capsule. They're going to have that synovial fluid as well. So all those things are going to be common characteristics for these different joint types. And so if we look over here in the structural categories column, we've got 6 different types: the plane joints, the hinge joints, the pivot joints, the condylar joints, saddle joint, and ball and socket joint. And these are kind of what I would consider to be the more common names. We have other names that are more anatomically based names. These are kind of a little more of the layperson name. And that's what this book uses. I think your kinesiology book might use these same terms too, but it's good to know the other name, but you don't need to know it for any test questions. So our plane joints are, the other name for those is arthrodial joints. All of these joints, these synovial joint types, are all considered to be diarthrodial. And diarthrodial just means that it's like 2 different bones, essentially, that are freely moving. And the arthrosis just means a joint. So our plane joints, this book classifies them as uniaxial. Most other references that I'm familiar with either consider plane joints to be multi-axial or non-axial. there's no true axis of motion. When we look at the hinge joints, there's a very distinct axis of motion. So our elbows are a hinge joint. If we look at this elbow right here, yeah, you can see that pretty well. The only thing it really wants to allow, the only motion it wants to allow is flexion and extension, bending it up and straightening it out. It has this one in particular because it's got wires holding it together, is like a true hinge joint. Our own body, we have a little bit of other motion going on there, but our elbow and our knee are considered kind of the classic hinge joints. They only really are meant to go in one direction. Our plane joints are basically two flat surfaces that can go kind of in every direction. I can go front to back, I can go side to side, I can kind of twist relative to each other. So it allows for limited motion in kind of all different directions. And so that's kind of what's normal about a plane joint. And so I definitely don't agree with putting it in this uniaxial classification, because most of our plane joints move in lots of different directions, depending on what motions we're trying to accomplish. If we look at our foot, we've got a number of different joint types in the foot. These joints in between all these tarsal bones are all plane joints. So we have a flat surface at the end of the calcaneus that's bumping up against the flat surface of the cuboid. We've got a flat surface at the end of the talus here that's bumping up against the navicular. And when we step down on our foot and put weight on it, that foot can flex and flatten out a little bit. And that's because we have limited motion at all of these joints to let us kind of bear weight, absorb some shock, and flatten out. Now, if we're walking on an uneven hillside and our foot needs to twist, it has the ability to twist in this plane. And that's because, again, we have these plane joints in here that allow us to kind of move a little bit of wiggle room in multiple different directions. So the whole forefoot can go side to side. We can twist it, and we can flatten it out a little bit. And so the ability of the foot to kind of move that way is because all of those tarsal joints are plane joints. They don't only allow motion in one direction or two directions. They kind of give a little bit in every which way, and it lets our foot have enough flexibility to kind of grab the ground, especially if that ground is more uneven, and adapt to changing surfaces. We can put our foot in, shoes that have high heels, and we can kind of adapt to that. A lot of that's coming on that extra motion that you need to where heels is coming at the toe, but it certainly is going to change the dynamic of all these more proximal joints at the back of the foot where those tarsals run together. So other examples of plane joints, much like the foot, are going to be all those little carpal bones in the wrist. Same kind of thing. Our hand can go this way. Our hand can go this way. We can kind of twist it a little bit side to side. And that's mostly because all those little carpal bones can kind of glide against each other in every different direction to let us maneuver our hands the way that we need to. And then we've got a bunch of plane joints in our back. All of those facet joints where the vertebrae overlap each other, and we've got that the underside is the inferior articular facet of the vertebrae above. The top side is the superior articular facet of the vertebrae below. All those things can glide against each other too. The shape of the rest of the vertebrae and the orientation of those facets can limit how much motion they have in all the different directions. So they're not quite as variable in motion as, say, the wrist and the foot joints would be. The spine is a little bit more limited because of the bony structure itself, because it's not just these little short bones that are fitting together. It's these irregular bones that have kind of more of an interlocking puzzle piece kind of setup. So we do have some other plane joints too that we'll talk about, but those are kind of some of the more common and kind of visible examples that we can think about.
So is the TMJ a plane joint?
The TMJ is considered more of a hinge joint because of its ability to do this. The function of protraction of protruding our jaw out and back, that's more similar in action to what a plane joint would do. We have those joint surfaces kind of sliding against each other and not really having a rotational axis. But when we look at opening and closing our jaw, that's more of a rotational axis. We change the angle and we drop the jaw down, and then we narrow that angle down and we pull the jaw back up. So we are kind of pivoting from this hinge joint right here with the opening and closing. But yeah, for sure, the protraction and retraction, sticking the jaw out and then pulling it back in, that is essentially like a plane joint. So that's where the TMJ is kind of funky, kind of defies classification, although most texts will consider it a hinge joint primarily. So we have a few joints like that, but it's kind of the exception to the rule. Now our pivot joint is also going to only allow motion in one plane. And our pivot joints, we don't have a lot, but they're going to be involved in rotational movements. So when we look at the atlas and the axis, that's kind of our classic, one of our classic pivot joints. This is our, which bone is this?
Isn't that the first cervical vertebra?
So it's not going to be the first, it's going to be the second. And so what's its name?
The axle?
So close. So it's the axis. So the axis, and again, that dens, that odontoid process that sticks up, that's the axis. And C1, the atlas, is the one that's really hollow. It doesn't really have a body in here. It's just got a hole. And it's so that that axis can fit up in that space. And so that gives these two bones the ability to rotate around each other. We're going to have a ligament that runs underneath it to kind of hold that axis in place so it doesn't shift and allow things to compress into the spinal cord, because the spinal cord's in this space right here. But it does give it the ability to really twist and rotate a lot. We can turn our heads, for most of us, about 90 degrees each direction. So we can look all the way straight across our one shoulder and then look all the way straight across the other shoulder. About half of that motion is taking place just right here. So essentially 45 degrees in each direction is because of the fact that this is a really mobile joint with that motion. It doesn't allow much other motion because it's uniaxial. It's designed to only allow for that rotation to take place. So it's really good at that. The rest of the cervical vertebrae, if we look at the skull here, between C2 and C3, between C3 and C4, we're just getting like 3 or 4 degrees of motion with each of those articulations. But if I try and twist this guy's head and hold his trunk stable, well, it's a pretty good model, except for that part where his whole head just collapsed. But most of that rotation is, like I say, is taking place between C1 and C2. His sutures were not very stable, apparently. He needs some surgery to fix him. But yeah, he lost his jaw and his crown of his skull. That was pretty good. So I would not, if I decide to advertise as a chiropractor, don't trust me, because bad things could potentially happen. But like I say, between C1 and C2, most people estimate we have about 45 degrees of our total cervical rotation just at that one joint. The other 45 degrees is essentially coming from like the 6 lower articulations. So it's a good setup in that, you know, we get the rotation that we need to be really functional and have good awareness and turn our heads lots of ways. But that C1, C2 articulation, what we call the atlantoaxial joint, is where we're getting most of that rotation. Our other really common pivot joint is going to be at the elbow, and I guess you can see it's where, I don't know if this one might work better. It's essentially where the side of the head of the radius is fitting in on the side of the ulna. And there's a notch right there. So that ulna has what's called the ulnar notch. It's essentially just a little indented area. So this round radial head has a good little place to fit. And it spins in that place. And because it spins, it gives us the ability to turn our hand over and back. So we have pivot joints, both the distal radial ulnar as well as the proximal radial ulnar. And so that's what gives us that ability to rotate. It has nothing to do with our ability to bend our elbow this way. That's all about the hinge joint. That's the humeral-ulnar joint. But the ability to turn our hands over and back, it's not really taking place at the carpals. It's taking place where those two forearm bones meet. That's where we're allowed to have that rotation and what gives us that motion. I don't know how well you can see this. This has the humerus and the ulna, but it doesn't have the radius on it. And so right here on the side, where there's no paint, that's the radial notch. So the ulna has a radial notch. The radius has an ulnar notch at the other end, where this inside edge of the ulna is going to spin relative to the radius. So those two bones have reciprocal notches, essentially, that let that motion take place. And the radial notch on the ulna is more significant and deeper, and the radial head is very much round. Let me look at that. Let me find a radius real quick. Find it. All right, so there's the top of the radius. So if I hold it this way, you can see that it's very round. And so that's what's going to fit against this notch on the ulna and just spin in place. So that's our pivot joint. Again, C1, C2, the atlantoaxial joint, and then primarily the proximal and distal radial ulnar joints are pivot joints. So again, plane joint, I wouldn't classify it as uniaxial. Hinge and pivot, every textbook I've ever looked at does include those as being uniaxial. So when we look at plane joints, again, they can move in all different directions. And when we talk about the body and we talked about the planes early on in the semester, I guess like that first day, probably we had those three planes. We had that sagittal plane, we have that frontal plane, and then we have that transverse plane. And when we reference things to anatomical position, the hinge joints really just work in the sagittal plane. If I'm standing up, my hinge joint at the elbow, all it does is let my limb move through the sagittal plane. It's just moving anterior to posterior. Same thing at my knee. I can just bend and straighten, but in anatomical position, it's just allowing my lower leg to move posteriorly. I wore pants today for you guys because it's colder mostly. So if I'm standing here and bending, my leg is moving posterior in the sagittal plane or moving anterior in the sagittal plane. So our hinge joints really just work in the sagittal plane. Our pivot joints, if I'm standing here, if I'm turning my head side to side, so C1 and C2 are really letting that motion take place. What plane is that taking place in?
Is it the transverse plane?
It's going to be our transverse. So all of our rotational motions take place in the transverse plane. And same thing if we look at your forearm, if I'm in anatomical position, then I'm just twisting. I'm going from palm facing you to palm facing backwards, palm facing forward, palm facing backwards. It's turning around a vertical axis and rotating in that transverse plane. So hinge joints are going to work in the sagittal plane, and pivot joints are going to work in the transverse plane. When we get down to the biaxial joints, the condylar joints are going to allow for motion in 2 planes. So we've got that bi in that name. And so our most common condylar joints are going to be our big knuckles in our hand. This is the one that's easiest to kind of think about. We can move our fingers at those joints in flexion and extension. So if I don't bend any of the distal joints, I can do flexion and extension, or I can splay my fingers out and I can do abduction and adduction of my fingers. So those are the 2 planes. So if a body part moves in, if I do flexion and extension, that's sagittal plane motion. So that's like a hinge joint. But when I do ab and abduction, spreading my fingers out and pulling them back together, then that's moving in the frontal plane. If you think about being in an anatomical position and standing up like this, if I spread my fingers out and then pull them back together, that's moving this way and back in. So those were kind of our frontal plane motion. And do that. This book classifies the saddle joint as being biaxial. Some other references consider that to be multi-axial, where it has even more motion than just 2 planes. And a lot of books will only say that we have just one saddle joint in the body, and that would be this one right here, where the base of the thumb, the metacarpal for the thumb, is going to run into that that proximal carpal bone. What's the name of that one that's at the base of the thumb? Everybody's muted.
Does it start with an H?
It does not.
The trapezium?
Trapezium is at the base of the thumb. Okay, so where the metacarpal for the thumb hits the trapezium, that's our saddle joint. This textbook that we're using also considers your sternocleidomastoid joint to be a saddle joint too. And a lot of books will consider that to be a plane joint. We'll look at that joint a little bit later. So some of these, there is some dispute between anatomists about exactly what class some joints in the body are. But for sure, the saddle joint right here is going to be the one that gives us the thumb the ability to go flexion, where we bend things, extension. It gives us the ability to pull that palm away from the body. That's considered abduction and adduction. But then it also gives it the ability to kind of move diagonally across our palm. And that gives us the ability to grab onto stuff a lot more effectively. So we have what's called opposition, is the ability to bring that thumb kind of diagonally across the palm. Flexion is if I just bend it across the palm. And then abduction is when you pull it out away from the palm. So the thumb's kind of funky because it doesn't work in those same planes. It's put onto our body kind of at a diagonal position. So it kind of defies the rules of flexion happening in the sagittal plane and abduction happening in the frontal plane, just because of how it's located. We'll kind of look at the thumb individually a little bit more as we go, I think. And then our last joint type, we've already kind of talked about the ball and socket joints. Those are considered our true multi-axial joints. And so if we think about our shoulder, if I'm in anatomical position, I can move in the sagittal plane, flexion extension. I can move in the frontal plane, do an ab and adduction, and I can also move in the transverse plane by internally rotating and externally rotating. So that rotation, I can do just my forearm, and that's going to be those pivot joints down here. But if I try not to move my forearm, I can also just rotate my humerus in place. And that's because of that ball and socket arrangement. Let's look at our hip. Trying to get the individual bones because that skeleton's a little too locked down for me to demonstrate this. So if we look at our hip, we've got this big, big ball. We got this big, big socket. And so this is a right os coxibone, a right femur. And so if I'm standing like this, I can flex it, I can extend it, so front to back. I can bring my leg out to the side, I can bring it kind of across my body a little ways, and then I can also rotate it. Let me get off the trochanter. So you can kind of see that greater trochanter going back and forward, depending on if I'm externally rotating it or internally rotating it. And because we have this nice round head and this nice round socket, it gives us that ability to move in all three of those planes. And the shoulder is going to be the same way. So those are kind of our classic ball and socket joints when we look at that. All right, how are we doing? Any, oops, let me let Audrey in. All right, let me skip through these because we kind of already talked about all these details. Let's look at the pictures anyways. So there's our gomphosis. You can see this tooth, looks like a molar. All these little white bands that are running horizontally are the ligaments. And then you see all this outline of where we have trabecular bone. And so that's the actual jaw. So that would be the mandible, all this kind of lattice work of bone through here. And then the actual tooth with all of its internal structures is shown as well. So that's our gomphosis. There's our suture line, our two fibrous joint types. And from a functional classification, what do we call those two types? So we have the three different functional types. Fibrous is the structural.
So wouldn't that be fibrous?
So the fibrous, the cartilaginous, or the synovial refers to the structural classification. I'm asking more about kind of functional classification.
Is it the synarthrosis?
Yeah, so these two are both going to be our synarthrosis, where we really don't want to see much motion taking place. Over here, we've got our syndesmosis type, and that's considered amphiarthrodial. So that's gonna be that interosseous membrane between the radius and the ulna that does give a lot of stability. So it is fibrous in that's just fibrous connective tissue, but it still needs to allow for some motion to take place. So this is our amphiarthrodial from a functional standpoint. These other two on the left and the center are going to be our synarthrodial from a functional standpoint. And then our cartilaginous ones, the primary ones that I want you to know for this really are going to be the synchondrosis, are going to be that between the rib and that little section of cartilage, or between the sternum and that little section of cartilage. So we do have synchondrosis joints both medially at where the sternum hits that cartilage, as well as a little bit more laterally where the rib hits that cartilage. This book considers the epiphyseal plate in a growing child to be a cartilaginous joint. I don't, and I don't think most other references do. This is not a place where the bone is meant to move. While it might be a cartilage connection between these two bony pieces until that child matures, it's not really supposed to be a movable part of the joint. We want the ends of that bone to be where motion occurs. So most references don't consider that to be a joint, really. The synchondrosis is usually just those sternum and rib articulations. And so this is going to be, these two are going to classify as the synarthrosis. We don't really want motion taking place. Again, the cartilage can bend, but not the actual attachments where the bone hits the cartilage. We shouldn't have motion there. And then down below, the symphysis, we talked about the vertebral discs. These are amphiarthrodial, so they do allow for limited amounts of motion, but they're mostly about making that joint stable. And then we also have in the front of the pelvis, joining that right and left pelvic half, the two os coxa bones together, we have a pubic symphysis. Again, just a nice cartilage chunk right there in the center. That's holding those things together. All right. So with our synovial joints, let's look at those real quick. We'll kind of talk a little bit more detail about these because these are the ones that we're mostly concerned about in therapy. We have a lot more effect and we treat a lot more problems with synovial joints. We don't really do a whole lot with the fibrous joints up here. The syndesmotic joints, yeah, we can help those move a little bit better when we look at trying to improve pronation and supination of the arm. But we're not usually trying to do a whole lot with most of those other joint types. So all of our synovial joints have that capsule, that kind of sleeve of connective tissue that's encapsulating. It's going to go from the more proximal bone and cover the end of the more distal bone as well. It's a two-layer thing. So kind of like when we talk about all those cavity membranes in the body, we have the parietal layer and we have the visceral layer. These joint capsules are kind of set up the same way. The outer layer is going to be the more protective layer. The inner layer is going to be the layer that's actually making synovial fluid. So that double layer, each layer kind of has its own unique role. So the outer layer is much more collagen based. A lot of stiffness and toughness that helps keep the bones attached to each other. The synovial membrane is going to be more epithelial cells, where we have secretory cells that can make that synovial fluid. So two distinct cell types and very different structurally, but they are bound together. So that we've got our tough outer layer, we've got our secreting inner layer. We've got the ends of the bones have that articular cartilage, and that articular cartilage should be nice and smooth, hopefully. And then we have some space. So we have a little bit of open space in those joints. And we need that open space so that when we try to bend and move a joint, it has some freedom to move. If that joint capsule really held those two bones very, very tightly together, well, it would be more like an anterior arthroidal joint. It would have a hard time moving. So we kind of need a little bit of looseness and a little bit of space so that as those bones move relative to each other, there's some room for them to do that. So it is stabilizing the joint, but it needs to be loose enough to let motion occur. And when we look at like the joint capsule for the shoulder, it's actually very loose. A lot of times they'll actually kind of depict it as having like this saggy little pouch kind of right in here. And we need that saggy little pouch on the inferior side of that capsule so that when we raise our arm up, it can stretch and give us that motion. If everything was held really tight underneath there, I'd go up to about here and then that tissue would grab and I wouldn't be able to reach all the way up. So particularly when we try and raise our arm overhead, we really need that extra capsular space on that bottom side. All right, and inside that cavity is going to be the fluid that inner layer of that synovial membrane is going to produce. Again, it is very oily feeling, so it is pretty slick. So that's that lubricating function. The ends of the bone where the cartilage is don't have a great blood supply. I think we've talked about that a little bit. When you get damage to that cartilage, the body has a hard time healing it. And the cartilage cells actually do get some of their nutrition through the synovial fluid rather than through the bloodstream. So it's kind of a unique, usually we think of the blood as being what's delivering everything to the cells to stay viable, but that synovial fluid does help a little bit since the circulation is so weak to that articular cartilage at the end of the bone.
So when somebody says, I broke a rib, are they breaking the bone or are they damaging the cartilage?
Breaking the rib, usually, the bone itself. Usually rib fractures are going to be, somewhere in here. Kind of depends on where the force was from. But if you're like in a car wreck and another car smashes into your side, something like that, you're breaking them in here. Now you can have the cartilage detach and cause a lot of problems and pain, but it's not the same as a fracture there. All right, all of these synovial joints are going to have ligaments to some degree, and ligaments should be thought of as your static support for the joint. They're going to tend to reinforce what the joint capsule is doing and specifically prevent motions in certain directions. So different ligaments will stop different joints from moving one way or the other. If you look
Hey,
at,
Craig?
Yep.
For long distance runners, does that joint cavity wear and tear because of how much they're using it?
Not really. The joint cavity tends to be pretty good. The problems that you typically get with the joints are usually less with the synovium and more with the ends of the bone, with the cartilage.
Oh, I guess I should say, is there anything that occurs with the synovial fluid? Since it's like a shock absorber, is it?
It does help with shock absorption. The synovial fluid, when we move the joint, it helps move it around. And so when we can move around that synovial fluid, it actually kind of helps with the lubrication function, and it helps with the delivery of nutrients and to the actual ends of the bone. So motion is considered to generally be good for the health of the ends of the bone, as well as for just keeping that synovial fluid moving. So it is definitely something that we want to encourage, is that extra motion. When we don't move a joint, then we have more problems than when we move it too much.
So there's no extra damage because of that amount of absorption it's taking when, because I know like long distance runners, as they keep going, it's just like a long period of time that they're continually moving that area.
They are, and typically if you don't have prior history of problems, then it shouldn't really create new problems as long as you adapt slowly and kind of build into things. People that typically have more, and usually people associate knee problems, the people that usually have knee problems from running are people that have prior knee injury. They've had a previous ACL, they've had cartilage damage previously, they've torn a meniscus. The sports that are really harder on your knees than long distance running are going to be things where you're doing a lot of stopping and starting and cutting, and those are the things that are going to really cause damage to your knee. And then it's when those folks that have that prior history try to run, their knee's not really, it's not in good shape for that activity. So if you have overstretched ligaments that let your bones move too far, then you're going to start having joint surfaces that rub in the wrong place. And when we have joint surfaces rubbing in the wrong place, that's what's going to kind of stimulate erosion of the ends of the bones and encourage arthritis to kind of develop.
Gotcha. Okay.
Other factors too. Certainly, if you carry too much weight and you try and run on your knees, that can be harmful for them. If you have bad biomechanics, if you don't keep things lined up real well, if you're running on harder surfaces, that's going to contribute to more impact and more potential erosion. If you don't have proper footwear for your particular running stride and type, then those things can all speed things up. There's actually
like on a therapy aspect, if you had somebody come in that was struggling with obesity, would you want them to start out like with walking, or would it be more just to like not have that much impact?
Yes. Yeah. Walking would definitely be safer. It would definitely be a less impactful activity than running. It would definitely be a good idea. Certainly there are people that are really heavy that take up running and can tolerate it. But there's definitely a lot of cases where being too heavy is going to put too much stress.
Okay.
And you'd be better served by doing less impactful activity.
So with the synovial joints and the synovial fluid, that's where a lot of your swelling comes from, right? Is that synovial fluid?
Yeah, you can get an overproduction of it, and certainly you can, if you have a more traumatic event like an ACL tear, you're gonna have a lot of bleeding in the joint when that ligament tears. But if you just have if you haven't had trauma like a sprained ankle or an ACL tear, you can get changes in that fluid production. So if you ever heard of somebody having water pulled off their knee, it's not really water that they're taking off of their knee, they're taking out synovial fluid, because essentially that space is too full. If you've got too much fluid in there, it's going to restrict the motion. There's too much internal pressure, and it becomes painful and can make it hard to move. So yeah, swelling can for sure be caused by too much synovial fluid. All right, so let's look at this knee. You guys are looking at the front. Let me back up maybe just a little bit. So you can see the patella. This is our coming down off the quadricep. They've obviously chopped through the femur down there. But what I wanted to show is kind of on the sides, we've got two ligaments. We've got this one that's connecting the fibula to the femur. And then we've got this one here that's connecting the femur to the tibia. And so this is commonly called the MCL, or medial collateral ligament. The one that goes from the fibula to the femur is the LCL, or lateral collateral ligament. And so these two ligaments are on the sides, so they don't do anything to really impair the ability of the knee to bend and straighten. When I bend it, they actually have more slack to them because the bones are moving closer to each other. What they're really designed to do is to prevent basically movement in the frontal plane. We don't want that tibia to move side to side relative to the femur. We want it to be stable in that direction because this is a hinge joint. It's supposed to function in this motion, in flexion and extension, and we don't really want it to go side to side. And so when we do get too much force, I don't know if you can, if I stretch this, you can kind of see that that ligament becomes under more tension. It's going to get skinnier, and if I go too far, it would tear. And so that's would be an LCL tear. So we don't want those things to tear. They are meant to give us side-to-side support, but they're not meant to interfere with front-to-back kind of motion. So that's just kind of an example of some really prominent ligaments that you can see.
There's a lateral rotation in the knee, right? Like
There's yeah, it does rotate a fair amount considering it's a hinge joint, but that rotation isn't really considered to be a motion that we can really distinctly control. It's what we kind of think of as an accessory motion. It happens because of the way the bones kind of fit together, and as we move things, we do get some rotation, but it's not that we have specific muscles that are making it rotate very effectively.
So if we have a hyperextension, do those expand and then get too loose, and so your knee's not as stable?
You could. The hyperextension is more usually related to the internal ligaments. So if I move the kneecap out of the way and bend it, I don't know how well you can see some ligaments inside there. So that's your ACL that I've got my fingertip on right there. If you turn around to the backside and look at it from the backside, then that's showing you the PCL. So that ACL, if that's too long, that's going to allow the knee to kind of hyperextend a little bit and can create some of those problems associated with that. So it's less about the medial and lateral ligament, and more about the ligaments that do help support things anterior, posterior. It's a good question. All right. Let's see. I'm gonna have everybody find your LCL real quick. So if you cross your leg like I'm doing right here, and go to the outside of your knee, right now in this position, that outside part of your knee is going to gap a little bit, so it makes it easier to kind of feel things over there. If you go over there and you find the head of your fibula and just kind of walk your fingers up, you're going to feel that lateral collateral ligament very easily on the outside of your knee in this position. It's going to be a narrow band, depending on how big of a person you are, probably not be a little bit thicker than like this twine, but not huge in most cases. So that's a really easy ligament to feel, especially in that position. The medial collateral ligament, if you come to the top of your knee, you can also feel that. It's easy enough to feel. If you're feeling along the tibia, you can feel kind of the ridge of the tibia, and as you work your way back, you're going to run into a structure that's running vertically, and that's going to be your MCL. So the LCL and the MCL are pretty easy to find because they are really superficial ligaments, and it's a big joint, and so they're considered to be pretty big ligaments. You can't really put a finger on the ACL and the PCL because they're too surrounded by stuff. but that LCL and the MCL are pretty easy to find. The newer term that they're trying to encourage people to use is naming those ligaments by the bones. So you'd have the tibial collateral ligament and the fibular collateral ligament, as opposed to the LCL and the MCL. The LCL would be the fibular collateral ligament. The MCL would be the tibial collateral ligament. So you will hear that too. Collateral just means it's on the sides. Collateral, so it's on both sides of the joint. So we have a lot of collateral ligaments that are holding bones together. All right. So here's our picture of a synovial joint, and this is probably some of the finger joints. Our fingers, we talked about these joints right here, and what kind were they considered? If you make a fist, what we think of as your knuckles, what kind of joints? They're synovial, so I'll give you that one. So we've got 6 synovial types. Which of the 6 are those considered to be?
Condylar.
Condylar. So condylar are biaxial, so they give us those 2 different motions. When we go further out and we get to what we call the interphalangeal joints on the fingers themselves, those are just hinge joints. So they don't have the ability to go like this. We can wiggle them a little bit side to side, but they're not really, there's no muscles running side to side to help us control that motion. All we can really do at those joints is flex and extend. So those are considered hinge joints. And that's what we're kind of looking at here, is probably more of one of those IP joints, interphalangeal joints. So the white connective tissue on the outside, that's the fibrous layer of that synovial capsule. The purplish kind of inner layer, that's the layer that's going to have epithelial cells that are producing the synovial fluid themselves. We've got this space in there, so you can see how the capsule kind of pooches out, and it pooches out like that so we have, again, room to move. If they were really tight, then we'd be really restricted in how much motion we have. The ends of the bones have that hyaline cartilage, that articular cartilage, and it is considered to have a limited ability to kind of absorb some synovial fluid. And then when we compress the joint surfaces together, it kind of squishes back out. So think of like a sponge. If you put it in water and kind of let it soak up the water and then you push down on it, how the water is going to kind of squish out. That's kind of how they theorize that synovial fluid can be kind of soaked up into the ends of those bones and help with some of the nourishment part of things. But then when we weight bear, like say for our knees or our hips, the bones in our feet, as they compress together, it's going to kind of squish out slowly, and it helps with some shock absorption in that way. So it does help with that a little bit.
So is the synovial fluid helping, like, for example, I have issues with my knees, but if I get a proper night's sleep, they feel amazingly better in the morning. So that's a result of the synovial fluid helping with nutrients and recovery, or what's going on there?
I don't know if it's so much, it might just be maybe the position that you slept in might make it feel better in the morning versus some other day. You might have your knee held in an awkward position for a couple hours, and maybe that contributes to it. It could be related to what you did the day before. You know, if you're on your feet a lot, if you did some other activities that were more stressful for the knees, then you might be feeling it more the next day. But I don't know that it would necessarily feel good because of that. Because again, if we move the joint, then that helps the synovial fluid move around the joint and better lubricate and nourish the ends of the bone. And when we're sleeping, we're not really moving all that much. You know, yeah, you're going to move some, but not like if we're walking around or something like that, or pedaling a bike. So pedaling a bike is a great way to just get synovial movement going at the knee without impact, especially if you don't turn the resistance up and you're just kind of spinning, very light resistance. That's a great way to encourage lots of synovial movement. So when people have cartilage injury to their knee, that's one thing that can maybe help it heal itself a little bit better if we can have just a lot of repetitions of motion, but with very little resistance. So you're not making them work hard, but you're just making that fluid move a whole lot. So that can be pretty helpful.
Craig, I have a question about
Yep.
tendinitis.
Uh-huh.
So how does tendinitis occur? Like, does that have to do with the synovial fluid? Is it just inflammation?
Tendinitis is going to be outside the joint capsule because it's going to be where the tendon is attaching to the bone or where the tendon is transitioning into the muscle.
Okay.
That we get some sort of irritation, overuse, too much tension on it. And most tendinitises are going to develop with, overuse type of thing. If you're doing that same motion repetitively all the time, it can put too much stress on it. And so it's going to be, those tendons are going to be outside the joint capsule.
Okay.
Some of our ligaments are embedded within the joint capsules. Some of them are kind of on the perimeter of it. So like the MCL and the LCL that you can really easily feel, they're kind of sitting on top of the joint capsule. But some of our other joints, the ligaments are really just kind of a thickened area within the capsule. But the tendons are going to be definitely outside of the capsule itself.
Okay, thank you.
All right, let's talk about what else we have in these joints. And then we're getting close to the end of official class time. So it's been good, hopefully getting a good understanding of all these joints. So we definitely going to have nerves in there. We need nerves to help for protection so we can feel pain, so we know when to stop moving, or we know when to take weight off of a joint. If, say, we start to sprain our ankle, we want to get those pain messages that help us recognize, oh, your ankle's going too far. But we also have just what we would consider to be more mechanoreceptors that are just giving our brain information about tension and angles, how far is it bending. So when we put more tension on the joint capsule, you're going to have receptors in that joint capsule that are telling us how stretched that tissue is, how much force is being transmitted through that. And again, it's just a way to make us aware of foot placement. If you think about walking on an uneven surface, like a rocky trail or something like that, and our feet are having to kind of do this every time we step, we're not hitting a nice flat sidewalk. We need that sensory feedback so we kind of know when to fire the muscles that are going to support and correct that motion. So if I'm on my left foot and my left foot starts turning too far out to the side, I want some muscles on the left outer side of that lower leg to fire and turn my foot the other way, so it doesn't let it keep going and sprain. So when you have that quick enough ability to react to an unstable surface, part of that's because you're getting good sensory information that we then connect with the motor plan that we need to do to fix things. So we need that feedback so that we can have the appropriate reaction muscularly to keep things stable when it's working right. We're going to have a fair amount of blood vessels. We're making synovial fluid, and anytime a cell is making something, it needs blood flow to keep that process going. So we do need pretty good blood flow to the joint. Most of our joints are going to have a lot of different bursa, and a bursa is essentially a little fluid-filled sac that takes away friction. And we'll look at a picture of where some bursa are in just a second. But they're usually kind of roundish, and they can get swollen and cause a condition called bursitis that can be pretty dramatic, where people look like they have like a big egg on the back of their elbow or something like that if you get a bad bursitis back there. Sometimes the inflammation is really subtle and you don't really visibly see it. Other times it can be pretty large and you might actually see a big swelling if a bursa is this one. It's going to be different than just joint swelling where the whole area is inflamed. It's going to be one distinct little fluid-filled cavity that's like a little balloon that you put too much air in, kind of thing. It's going to be really, except it's going to have fluid in there. But they are meant to reduce friction between overlapping structures, between ligaments and bones, between tendons and ligaments, between tendons and the joint capsule, when we don't want a lot of friction. And so those bursas help to reduce friction, essentially. Some of our tendons running from our muscles to our bones are going to have sheaths surrounding them. And that lets the tendon, again, another way to decrease friction. If we have this outer protective covering, the tendon can kind of move back and forth within that covering without really affecting any surrounding structures. So if you think about like a bike cable for your handbrakes on a bike, you've got that usually a black outer plastic covering, and then inside you have the metal cable. So the metal cable is kind of like the tendon itself, and that black outer covering is more like the sheath. When you apply your brakes and you squeeze those handles together, it's pulling on that cable, so then the parts that clamp down on the wheels, the calipers, will activate and work. And that's kind of like making the muscle active, is clamping down. But the sheath doesn't change position. That cable housing just stays put, and the cable slides back and forth within it. So that's kind of how a tendon sheath is going to work with a tendon. It just gives the tendon a dedicated pathway so that it can move easily without really rubbing up against or irritating any other surrounding structures in the joint. And then we have a lot of joints that are going to have pretty substantial amounts of fat in them. The knee is the easiest example to kind of think of. And anytime you kneel, you're thankful that you have some extra fat pads in your knee. So it is okay to have fat knees. We want that padding a little bit. So this slide is kind of nice. It looks at a couple different things. This cutaway here, what joint is that? Well, it says on the bottom it's a knee joint. Stupid titles. So we're looking at a sagittal cut. So it's cutting it midway through the bone, essentially, so we can kind of see all these different structures. So we've got our quadricep muscle up at the top, coming down and attaching into the patellar tendon, or excuse me, the patella itself. Right in front of the patella, that little blue thing is a bursa. We've got two other bursa on the underside, going from the bottom of the patella down to where it attaches onto that tibial tuberosity on the tibia. So basically there's our, what we call the patellar ligament, and we've got a bursa on either side of it. So when we bend and straighten our knee, all these bursa are just helping the tissues glide past each other without creating a lot of friction. It's kind of like a ball bearing does in a lot of machines and stuff like that. It just gives those parts the ability to kind of roll past each other without really rubbing on each other and causing any kind of irritation. So those bursts are really important when they're not inflamed, they're great. But if they get inflamed, then every little movement you do is going to hurt a lot. And then we've got this other bursa on the back where our calf muscle is coming up and attaching back there too. So again, a lot of them are going to be located where those muscles are attaching to the bones, because that's where we have a lot of motion and potentially a lot of friction taking place. Over on this other slide, we've kind of got a depiction of the tendon sheaths in the palm side of the hand. And so the blue is meant to kind of indicate the sheath, and then the white part inside is the actual tendon itself. And so the sheaths basically stay put, and the tendon moves within the sheath so that we can glide back and forth pretty freely. All right, so we've already talked about that. We've talked about these joints types already. Let's go through this motion, and then we'll take a little breather here. So all these things just really deal with synovial joints. So our fibrous joints, our cartilaginous joints aren't going to fit these same descriptions, because we don't really want those joint types moving a whole lot. But for the synovial joints that are meant to move, we're going to have gliding motions, we're going to have angular motions, we're going to have rotational motions, and then we kind of have the exceptions to the rules, essentially these special movements. And so the special movements, that would be kind of like the, I guess kind of like the TMJ. The main motion that we want is angular, where we have that hinge occurring, but we do get a little bit of translatory motion when that jaw is going forward and backwards. So I think that's one of our kind of special motions. All right, let me go to gliding. So gliding is mostly going to happen with plane joints as a functional movement. And so when we look at that foot, again, if I'm trying to adapt to an uneven surface and my foot has to give, kind of twist this way, all these tarsal bones need to glide past each other just a little bit. It's a flat surface sliding against another flat surface. And depending on which motion we're doing in the foot, it can kind of glide every different way. There's ligaments that are attaching each of these bones to every bone on either side of it. So it doesn't have a lot of motion, but it can move a little bit in every different direction. And it's considered to be a gliding motion. When we look at the spine, let me get him straightened out here. All right, we'll just pay attention to the low back one. So again, if I let these bones move relative to each other in the back, if I'm bending and straightening a little bit, I'm getting some movement in between the bodies, and there's no discs on this model, so the discs have been taken out, but the gliding is really back here on the back between these facet joints. This flat surface here against this flat surface here is going to glide. And again, depending on which vertebrae we're talking about, it will help allow for certain motions, but not really allow for other motions. And these lumbar vertebrae in particular are angled, they're kind of coming straight out at you. So they can help us go into flexion and extension kind of freely. But as soon as I try to rotate, they're going to bang up against each other. And so they're not really good at rotating. They're pretty good at flexing, but not really rotating. If we go higher up in the spine, and we look at some of these thoracic vertebrae, the ones that look kind of more like giraffes, well, those angles are more at an angle to each other, and it lets them kind of go side to side without anything blocking them, but it also lets them go front to back. So we have a little bit more motion available, a few different planes at some of these vertebral joints than others. But those are kind of be gliding motions. Mostly going to be thought of as taking place in our plane joints. Angular motion is kind of what we think of, and this is kind of the easiest one to think about. These are the big motions. And so these are going to really take place with our hinge joints, our condylar joints are going to show lots of ability to have angular motion, as well as our ball and socket joints for sure. So flexion and extension. Let's just go through some of these pictures and we'll kind of talk about these. So flexion, the most common definition is moving the joint so two bones move closer to each other. So if I have my arm straight, my humerus and my forearm bones are pretty far apart. If I bend my elbow, now they're much closer together. So this is flexion, and then moving two bones apart from each other is going to be the extension. Hyperextension is essentially any motion beyond anatomical position. So if I'm standing up, my elbow doesn't really hyperextend, but my shoulder will. So if I'm standing here in anatomical position, I can go into flexion, I can go into extension, and then I can go into hyperextension. So in anatomical position, I would stop right here. Anything beyond that is going to be considered hyperextension. And so then same thing kind of with my hip, I can go into flexion, I can go into extension, and then I can go into hyperextension. Anything beyond anatomical position is kind of hyperextension. And the shoulder and the hip are meant to hyperextend. We want that extra motion. Other joints, if we hyperextend, it can cause problems like knee. If your knee hyperextends, you end up kind of putting too much pressure on the bones at the front of the joint and kind of causing some issues there, as well as potentially overstretching some structures on the backside of the joint. And a lot of people can hyperextend their elbows. Mine stops when it gets straight, but you'll see a lot of people that their forearm bones will kind of start angling downward a little bit. And that's not as big of an issue as at the knee, because the knee is a weight-bearing bone where the elbow's not really a weight-bearing bone for the most part. All right. Lateral flexion is also known as side bending. And so that's also considered to be an angular motion. What plane would that be occurring in?
Isn't that the coronal plane?
Okay, so this means the coronal plane. So we're going side to side, and we're getting a little bit of motion at each joint. when we look at going through the spine, for me to do that, and he's got a steel rod, he's not going to bend very well. Essentially, kind of like when we talked about cervical rotation, I had most of that motion taking place at C1, C2, and just a little bit at each additional joint. With lateral flexion, we don't have one specific segment in the spine that does that. It's just that each vertebrae can kind of do it a little bit. And we've got a whole bunch of vertebrae. And so if every vertebrae is capable of bending to the side by 4 or 5 degrees, then we can add it up and we can have a pretty good angle that we can go into side bending for or lateral flexion for.
I have a question about this example.
Uh-huh.
So it's labeled as lateral flexion. So she's flexing on her left side, but isn't it also lateral extension? She's extending her right side. So,
So
both those apply, or am I wrong there?
they use different term for it.
Okay.
So they just consider what's happening on the side you're bending towards. And then when you come back up, you're considered to have reduced the angle of lateral flexion. So it's not that I'm going into lateral flexion and then extending to come back up. This coming back up is termed reduction. So we create an angle and then we're reducing it, but they don't really talk about lateral extension. I tend to like side bending a little bit better from a terminology standpoint because, yeah, when you hear flexion, you think there's got to be extension too. But if you just say side bending, then that's a totally new term. And then we just reduce the side bending.
So that encompasses what's happening on the right side of her body as well?
Yes. Yeah, we name it by the side that they bend towards. And then when you come back to neutral, then it's just considered reduction of it. So they don't, yeah, there's no such term as lateral extension. It's just the way whoever came up with it named it. All right, 937. Let's finish going through these angular motions, and then we'll take a little breather, I think. So abduction are going to be in the frontal plane. It's basically raising the limb away from the body, bringing the limb back towards the body. The way that I think of it is everybody's heard of a child abduction. In abduction, the kid is taken away from the parent. And so if we're abducting a limb, we're moving it away from the body. If we're adducting something, we're adding it back into the body. So we're bringing it closer to the body. And a lot of times people will say like abduction and adduction, because when you say them quickly, they sound pretty similar. And you want to be really clear which motion you're talking about. Are we talking about a abduction? Or are we talking about a deduction? So you will hear people say that to try and emphasize and be really clear about which of those we're doing. The fingers and the toes kind of go by different rules. Normally when we talk about abducting, we're moving something away from the body. And so if I'm moving my whole arm away, yeah, that makes sense. When we're looking at the hand in anatomical position, if I'm standing like this with my hand by my side and I abduct my fingers, well, my pinky is moving closer to my thigh. But my index finger is moving farther from my thigh, and my thumb is moving farther from my thigh. When we look at the motion of the digits, we reference it to the digits themselves rather than to the body when we talk about abduction. So with the hand, we always use the middle finger. That's kind of what we're either moving away from or moving towards. When we look at the foot, we use the second toe. So the second toe is the big toe will abduct away from the second toe and then adduct back towards the second toe. The third, fourth, and fifth toes will abduct away from the second toe and back towards the second toe. But with the hand, we use that most central digit. And we definitely have more symmetrical movement in the hand than we do in the foot, and a lot more of it too. So they do use a different reference point, but in anatomical position, your pinky and your ring finger are moving towards your thigh when you abduct. even though we think of adducting being when we move something close to the body. So a little confusing with that. Now our final angular motion that we've got is this one here called circumduction. And it looks like a rotational motion, but it's not. It's essentially moving the limb in the shape of a cone. And any joint that is biaxial or multi-axial can do circumduction. So if it has the ability to move in multiple planes, it can circumduct. Our hinge joints can't circumduct. Our pivot joints can't circumduct, but our fingers can circumduct because our MCP joints have the ability to both flex and extend and ab and adduct. And it doesn't actually, circumduction doesn't include any rotation. It's just those 4 movements: flexion, extension, abduction, and adduction, and then kind of connecting them. So I can hold my hand steady and I can move my wrist this way because the wrist is considered a condylar joint. So I can ab and adduct it. I can flex and extend it. If I combine them together, I can circumduct it. The shoulder and the hip are ball and socket joints. So they have 3 different motions, 3 different planes they can move in, so they can circumduct really easily. Our head can circumduct. So I can move my head around in a circle like that. I can move my whole spine in circumduction if I'm just kind of doing this kind of thing. I'm circumducting my trunk. So you can circumduct, multi-segmental body parts, but you have to have that ability to do flexion. You have to move in the sagittal plane, and you have to move in the frontal plane to be able to circumduct. We don't technically need to rotate itself. All right, 9:42. I'll shut up, at least for 10 minutes or so. So take a little break. Let's come back at 9:52. Since my computer says 9:42, so about 10-minute break. We'll probably just finish going through these motions, and then we'll kind of look at individual joints and maybe play around with it a little bit before you guys take the quiz. But take about 10 minutes, and I'll see you in a few.
So Craig, all things being equal, I notice like when you see a skeleton, it has the teeth are intact generally.
Uh-huh.
So there's connective. We looked at a slide showing the connection between, that's actually a joint, which never occurred to me. So if you were to come upon a skeleton in that state, are you also going to see all the connective tissues? Do they all remain on a skeleton if it's not otherwise treated so that they're removed? Or is it just that particular stuff around the teeth that stays?
I mean, I think certainly the teeth, if they find a body and the teeth are in there and they're checking dental records and all that kind of stuff, they're not going to be held in place as well as they would if that person was still living. So anything that has a lot of water content in it is going to dry out and slough off kind of the longer a skeleton's out there. So things like joint capsules and ligaments and tendons do have a fair amount of water in them. So most of the time they're going to kind of dissipate in the teeth because it is such a deep socket. And I think those connective tissues are less exposed to the elements. Maybe they don't probably degrade as readily. And there's probably not nearly as much water content. Certainly the gums and things like that are all going to erode and dry out or get eaten by whatever maggots or other little critters that dissolve people or dying animals, dead animals, I should say. But yeah, some of the bigger connective tissues, depending on the age of the skeleton, might still be a little bit intact. But then once you start trying to move something around, they'd probably be really brittle and would tend to tear pretty easily and let those bony pieces start separating a little bit more. So I brought a friend in class, Abby. Good girl. So I know we have two Abbies in class, and that's my Abby right there. So good girl. Yes, good girl. She's a happy dog. My wife took her running this morning, so that makes her happy. She likes running, but she doesn't like it when it's hot. So she likes this weather right now. If it's above about 55, she's like, I'm done with that. She likes running in the snow, which is interesting because I've got her in Louisiana. So she's actually a very southern dog, but she does like the cold. So, all right. Let's finish going through these last few motions real quick. And then we're just going to start kind of going through the body, kind of joint by joint, and kind of talk about the different joint types, the different appropriate names, kind of I'll let you guys try moving things certain ways. You can kind of get a feel for how these joints are moving. And then the quiz today, a lot of the questions are those drag and drop ones where you have, 6 different labels to attach. So they don't go quite as quickly as just a simple multiple choice question a lot of times. So I'll probably let you guys start the quiz at 10:20. So just in about 25 minutes or so, and that'll give you a little bit extra time to work on it. So we talked about angular motion. We talked about gliding motions. And then we got rotational motion is kind of our other big type. And so these are going to be mostly seen with like our pivot joints, our ball and socket joints that do have that transverse plane motion. So the first couple that we've got are what are called either lateral or medial rotation. Lateral is the same thing as external rotation. Medial is the same thing as internal rotation. And so we see that with things primarily like the shoulders and the hips. If we look at my skeleton friend over here, actually he's probably not the best example. I'll probably just use myself because I move better than the skeleton. It's kind of fused together. So if I'm looking at my shoulder, we already talked about the 3 motions I can do. I can do the flexion, extension, abduction, and then I can do the rotation. The movement of the forearm, when I turn my palm down and I turn my palm up, that's considered that next set of terms on this slide. The pronation is palm down. Supination is palm up. A lot of students like to remember that by, if you're holding a cup of soup, you need to be supinated. So you need that palm up to hold that cup of soup. Pronated is palm down, just like lying prone is face down is prone, face up is supine. So that's kind of where those names come back to us a little later. We'll talk about, people being in different positions to perform techniques on them. Prone is face down, palm down is pronate, palm up is supinate. When we look at internal external rotation, the shoulder, it's that same longitudinal axis running straight down the length of the bone. The rotation is occurring here because of the way that head of the humerus fits against that glenoid fossa. And it can be hard to tell if when I do this standing up, is that because of what's going on in my forearm? Is that because of what's going on here? And so a lot of times when we look at internal external rotation, we'll have the people bend their elbow and or bend their knee. And so now if I do this, my forearm's staying in the same position. My palm's facing inward. And I do this, I'm doing internal rotation or medial rotation. If I go like this, I'm doing external rotation or lateral rotation. And so it is taking place up here when I move my arm side to side that way. You can put the arm out in this position. This is actually where we put the person when we're going to measure it using a goniometer. This would be external rotation. This would be internal rotation. Okay. Same kind of thing with the leg. If I can, let me see if I can tilt my camera down a little bit more. If I'm standing just like this, and actually that's too low. How about right there? There we go. I can go like this. I can go like this. So this is my internal rotation. This is my external rotation. Now my foot can move independently. So again, it can make it a little bit hard to tell. So when we typically measure that on people, we're going to have them sitting, and then we're going to go like this or like this. And this one always confuses people because you can't pay attention to what's going on with the foot. What's rotating is the femur. And so if I do this, my foot is turning in, but my femur is going out. If I do this, my foot is going out, but my femur is turning in. So while you're sitting there, assuming you're sitting there, kind of wrap your hands around your femur or your thigh. And I want you to practice just turn your foot out and kind of feel which way your thigh is turning. So if I bring my foot out, my whole thigh has to turn inward. So that's internal rotation. If I bring my foot towards the other shin, now my whole thigh has to turn outward. So that's external rotation. And we don't necessarily do it a ton. Certainly if you're trying to kick a ball or something like that, you're going to have some rotation going on at the hip to let you kind of do that diagonal path. But the other place where it really comes into play is anytime you're doing a twisting motion, you're going to have a lot of rotation going on at your hip. So if let's say I'm playing golf, I'm standing like this, I bring my club back, my feet haven't moved because they're anchored to the ground. My shoulders, my spine are clearly rotated because now my shoulders are facing the other way. My pelvis is turning, but again, my feet haven't moved. So what gives my pelvis the ability to turn is the fact that I'm rotating at my hips. And the hips are not rotating the same way. So if I turn here, I'm turning to my right. My right leg is doing one type of rotation. My left leg is doing the other type of rotation. So everybody stand up and let's try that. You need to move, right? And we'll see if we can figure out what's going on with that. So if you twist to your right with your feet planted, what is your right leg doing? How has it changed its relationship to the pelvis, where the hip socket is? Am I internally rotating on that leg, or am I externally rotating?
Internally.
So the right leg is internally rotating. My feet are still pointing straight ahead, but my pelvis is facing to the right. That's essentially the same thing as if I had was doing this. Your left leg is going to do the opposite. If my pelvis is facing this way, but my left leg is still facing straight ahead, my left leg has effectively externally rotated. And so if I'm doing a swinging type motion, a baseball bat or a golf club or anything like that, I'm rotating in one direction to kind of create my backswing, and then rotating in the other direction to do my forward swing or my hitting motion. Again, your feet are planted on the ground, but you're getting that force through rotation. And certainly the spine is rotating too. Your arms are rotating as well. So let's think about the arms. Same thing, if I'm holding my golf club and I've twisted to the right, what has my right arm done?
Lateral rotation, external.
External.
So it's going to be kind of opposite of the hips. My right arm is laterally rotating. My right arm is laterally rotating. My left arm is internally rotating in that backswing. But then when I go the other way, they're going to switch. Does that make sense? It can be hard. Those rotational motions can be a little tricky, especially when we get people measuring internal and external rotation and assessing strength in those internal and external rotating muscles. The lower leg trips people up when the foot is free to move. It's easy to get that confused. So don't pay attention to the foot. Pay attention to what's going on with the femur. Which way is that femur twisting? To let us know if we're rotating internally or externally. When we look at spinal rotation, we don't really talk about internal or external because we just have one spinal column. So we're just rotating to the right or rotating to the left. And then we just name it on which section. So if I keep my shoulders square and I just turn my head, then I've just done right cervical rotation. If I'm doing something like a golf swing or a baseball swing, well, I'm going to turn my head, but I'm also going to turn my thoracic spine and my lumbar spine too. Now, if you're doing something like baseball, well, really baseball or golf, if I'm keeping my head more fixed and I'm rotating, now we can kind of have the spine rotating in two different directions. My shoulders and my hips are going to the right. So my thoracic spine, my lumbar spine are essentially having to twist to the right. But in order for me to keep looking at the ball, my cervical spine has to rotate to the left to allow that motion to take place. Does that kind of make sense? If my head is still, but the rest of my body turns, I've essentially turned my head I'm looking right over my left shoulder. So that's just like doing this, cervical rotation to the left. But again, my trunk, I've rotated it the other way to go to the right. So our spine has the ability, like each section can kind of twist opposite from each other to a degree. Usually the thoracic and the lumbar kind of tend to move a little bit more in the same direction. Since they're adjacent to each other, it's a little bit easier to isolate that cervical motion. All right, let's talk about our special movements. And then that'll probably take us about to the end of class, I'm guessing. Yeah. All right, so these are ones that kind of defy description. They don't take place necessarily in a given single plane. A lot of them are unique to just one or two joints in the body. So we've got this term elevation and depression. And when we look at the jaw, we don't, even though it's a hinge joint, we don't call it flexion and extension. Depression is essentially opening your mouth. Elevation is closing it. So is your lower jaw going downward or is your lower jaw going upward? So that's jaw-wise elevation and depression. The other place that we have elevation and depression is with the scapula. So if I don't know how well you can see this. So if I'm standing like this and I shrug my shoulders, that's elevation. If I lower them back down, that's depression. And so we can do elevation and depression independently, but it also happens with other motions. So anytime I raise my arm up really high, that scapula has to elevate. When I bring it back down, it's going to depress. Now it does some other things too. When I raise my arm up, it's gonna rotate a little bit too, but it's gonna rotate and it's gonna elevate. And we do have specific muscles that help the scapula do that. And the scapula, because it's not really part of a true joint, it has a lot of weird motions that we don't see with most other joints. Let's go down about 3 slots. So we've got protraction and retraction. So those same 2 joints that we just talked about for depression and elevation, the TMJ and the scapulothoracic, can also protract and retract. And so we talked about the jaw already. The protraction is pushing that lower jaw out. The retraction is pulling it back in. Same thing with our scapula. If I reach out in front of my body, that scapula's got to move. So here's my scapula right here. When I reach out, it's basically coming around my rib cage to let me reach really far. And the farther in front of our body we reach, the more you're going to get scapular protraction. Scapular retraction is when we're pulling things back in. So anytime you're doing like a pull-up, you're going to be retracting. Anytime you're doing a rowing motion, you're going to be retracting. When we're typically doing any kind of a pushing motion, like a push-up or a bench press, we're going to be protracting. So we're protracting and retracting. And again, the scapula are basically going to move around kind of laterally around the rib cage and then pull back towards the vertebrae, towards the spinal column. So that's our protraction and retraction at the spine.
What would the stretching the rhomboid be considered?
Protraction.
Protraction, because pulling, okay.
Yeah, so the rhomboid's primary action, the motion that they create, is retraction. They're attached to the spine, they go out to the medial edge of the scapula, and they pull those scapula tight together. So their action is retraction. To stretch them, we protract them. So good question. All right, inversion and eversion. These are terms that really just apply to the foot. And the tibia here. This is the wrong tibia for this foot, and I recognize that. But let's say it's like this. So this side is my big toe. The other side is my pinky toe. So this is a right foot. It is a left tibia. Sorry, that's what I had out. If I turn my sole of my foot in, and this is the sole of the foot, that's considered to be inversion. If I turn the sole of my foot out, that's considered to be eversion. Okay, so it's kind of it's a frontal plane motion, essentially, kind of like abduction, because the foot's put on our body at a 90-degree angle instead of being straight in line, like say the wrist is with the hand. It's a little bit different as far as the orientation is concerned. But inversion, you're looking at the underside of your foot, you're turning your foot in. Eversion, you're turning your foot out. Okay, so we definitely want to know those terms. And then opposition, we've already kind of talked about. That's really just kind of this motion here, this kind of diagonal motion across the palm. All right. I think that's probably a good spot. Maybe we'll look at these first few joints on the body that we haven't talked about for just the last couple minutes. So we'll start at the very top. We talked about this guy at the beginning of class. This is our C1, so our Atlas. And Atlas had the weight of the world on his shoulders or whatever in like the Greek mythology, whatever. I'm not big on that stuff. And for us, our world is our brain and our skull. That's what controls everything that we do and where we have conscious thought and all that. So it sits right on top of there. And so if we look up close at this vertebrae, especially from the side, you can kind of see how this is scooped out. So this is what's called a concave surface. It's caved in. It has this little divot when we look at it from the side. When we look at it from the front, you can't really see that indentation. You can see kind of the front of those facets, but it's a little hollow spot right in there. And so that's where the skull is going to sit. If we look at the underside of our skull, we've got these little rounded projections right here on kind of on the front. Here's foramen magnum. Right on the front of foramen magnum, you've got these little rounded areas. And if I look from the side, maybe you can see how round they are a little bit. So this rounded condyle is what's going to fit right there. I don't know how well you can see that, probably not that well, where C1 is going to intersect with it. So we have a convex condyle, this rounded bump, and then we have a concave little spot for that skull to sit. So that skull sits right on top of that. And that concavity is only really in one direction. It's just kind of going from front to back, from back to front. So that joint between the base of the skull and C1 really just lets us do this motion. We have a little bit of ability to kind of go side to side at that joint. So it does rock a little bit side to side, but it can't really rotate. It doesn't really rotate. The rotation comes at the next level down, what we already talked about with C1 and C2, that axis and the atlas. So that articulation between the base of the skull and the top of the atlas, what we call the atlanto-occipital joint, called the atlanto-occipital because it's on the occiput is where those condyles are. It's considered to be biaxial or a condylar joint. So it's the same joint type as our knuckles. We can do that side to side motion in the frontal plane. We can do the front to back motion, the flexion extension. So that's occurring right there. So atlanto-occipital is the base of the skull where it articulates with the top of C1. When we go to the next level down, then we have atlanto-axial, and that's our C1, C2 joint. That's a pivot joint. So it's uniaxial. So all it does is this, side to side, rotation. And then when we look at underneath C2 to C3, from C3 to C4, all the way down to L5 to S1, those are all plane joints. So we have at the body of those vertebrae, we're going to have that cartilaginous joint. That we have the bodies of the vertebrae with the discs, but on the posterior side, where the facet joints are, those are all the plane joints. So the spinal segments are a little different because, again, we've got the articulations between the body, which are cartilaginous, and then we've got the articulations between the facets, which are synovial, and those synovial ones, they're plane joints, so they can move a little bit in every direction. But C1 and the base of the skull, and then between C1 and C2, those are distinctly different joint types. So we have a condylar joint at the very top, followed by a pivot joint, and then from there we just go to all the different facet joints that are plane joints at the vertebrae, and then those cartilaginous joints for the bodies and the discs. All right. We will probably pick up going kind of through the body joint by joint next class session, but I want to give you guys time to get into Canvas and get the quiz going. Any last minute questions here on bones for the quiz, on anything that we talked about today?
I have a question, Craig.
Uh-huh.
So I was a runner in high school, and they talked a lot about pronation and overpronation. What kind of movement is that?
So we have that term in the forearm, and then they do use that term for the foot and ankle also. It means different things in those different regions, just to confuse the issue.
Yeah.
The foot, when we talk about pronation and supination, it's kind of, those are considered to be triaxial motions. So let me find foot and tibia, and we can kind of show that a little bit. So when we talk about somebody pronating, it really means it's kind of similar. The biggest part of that motion is kind of similar to the eversion. It's that your foot is kind of pressing down more on the inside edge of the foot, If somebody's considered a supinate, it's more that they tend to put more weight on the lateral side of your foot. And normally when we're walking or running, we will normally make contact on the lateral edge of our foot, so we're kind of in a supinated position. As we bear weight, we kind of roll into pronated position, and then when we come back off, we kind of go back into supination. So they're both normal motions. Where we run into problems is if somebody excessively pronates, then they're going to tend to let their foot flatten out more, and that's what we see with people that have more flat foot. They'll tend to be overpronators. And so their foot gives too much and flattens out too much and rolls inward too much. The other motions that constitute pronation is forefoot abduction and then also dorsiflexion. So when we make contact, that pronated foot, you're going to tend to be in a more dorsiflex position. You're going to tend to be in a more forefoot abducted position, and you're going to tend to be in a more everted position. Supination is the opposite. So supination, you're going to tend to be in more plantar flexion, like this. You're going to tend to be in more of an inverted position, and you're going to tend to be a little bit more forefoot adduction. So we'll go into those a little bit more, I think, next time probably as well. But that is a common term, and if you go into any running shoe store, they're probably going to ask you or try and assess whether you overpronate or oversupinate, because certain shoe designs are more helpful for different patterns than others.
Thank you.
You bet. All right, other questions? All right, this should be pretty much about 10:20 on my computer. So if you guys want to get into Canvas and then click over to quiz 4, then you should be able to start that at 10:20. It's time to lock out at 10:45. So do your best to finish by 10:45. Otherwise, it's harder for me to track down your score. So you got 25 minutes, 10 questions, but almost all those questions are going to ask you about 5 or 6 different parts of the bone.
Do we keep the video on?
You can, yes, keep the video on, but then once you're done with the quiz, then you're feel free to check out. And we'll see you every Thursday. But I'll stay on, so if you have questions, send it to me through the chat, so that way we don't interrupt the rest of the class. And I'll put my chat back up because it's kind of disappeared on me again. There we go. All right, I'm gonna turn off my mic for now. But let me know, like I say, shoot me a message in chat if you have questions while you're trying to quiz.